So how about I'll just get started right now. It's 12:02, and again, I don't want to go past this 40-minute limit if there actually is one. So nice to meet you all. For those of you who I have not met before, I'm Andy Liu. I'm one of the newer gastroenterologists working here predominantly out of the Birchmount campus. Previously, I was actually in the United States. I did a neurogastroenterology fellowship, so GI motility fellowship in 2019 before moving on to Columbia University in New York, where I was staff there for a few years before being recruited back home. I'm very happy to be here. Scarborough is where I was born and raised, so very, very fortunate to be able to come back and serve our community. In terms of neurogastroenterology, certainly my interests span twofold. So the first half of neuro GI is upper GI. So that would be more things like achalasia, post-myotomy dysphagia, significant reflux, but I felt that that may be a little bit too specific for my talk. The other half of neuro GI is really constipation, and I feel like that might be more relevant to a lot of members of our audience today. So my talk is entitled Constipation. It's not just a just symptom, and a second just in quotations, because I hear that all the time. I hear them like sometimes on the inpatient wards or getting consults, people say, is it just constipation? Sometimes it is, but sometimes it could be very difficult to treat and manage, and the diagnostic workup can be quite challenging as well. Okay, so we'll begin with a question first. So first of all, which of the following patients does not have constipation? Okay, so we'll give four options, and I guess I should probably preface it by saying this constipation should be the chronic type of constipation. So the first one would be a patient who has one daily bowel movement, but who otherwise complains, but who complains of needing to strain to pass hard and lumpy stools. Option number two would be a patient who has three daily bowel movements, but who rarely feels completely evacuated and who just feels like there's always some type of obstruction down below that's uncomfortable. Option number three would be a patient who produces one soft bowel movement every 5 days. But as I'm sure we all see, lots of men in particular, they have no other complaints and they're really only told to come in to see you because their wife is getting angry at them. Option number four, a patient who has two bowel movements per week, but who frequently has to use a gloved finger to help them evacuate. Okay. So based off of this, in terms of defining chronic constipation, so you might hear the term chronic idiopathic constipation or functional constipation, we go based off of the Rome 4 criteria. For our audience members who are not familiar with this Rome 4 criteria, it's really it's a set of criteria that help us diagnose functional gastrointestinal disorders, so including constipation. So two or more of the following features. There are six of them in total. The first one is less than three bowel movements per week. So even if you have a bowel movement every 2 days, that's not constipated, less than three per week that we think of as being more concerning. Straining, so you need to have excess straining at least 25% of the time. Sensation of incomplete evacuation, again, at least 25% of the time. That would be a third criteria. The fourth criteria would be a sensation of anal rectal obstruction. Again, kind of like with our patient, they feel like there is something down below that's very uncomfortable and it's kind of a nuisance. Still at least 25% of time. Criteria five would be manual maneuvers needed, right? So that would be kind of like you putting a gloved finger, reaching into a rectum, pulling stool out. But if you were to ask a lot of women, young women in particular, sometimes they'll actually insert the finger up into the vagina, press posteriorly to provide some type of counter pressure to help them evacuate. That's specifically called splinting to help them evacuate, or hard and lumpy stools as defined by Bristol types 1 and 2 on a Bristol stool chart that I've referenced here, again, occurring at least 25% of the time. So based off the criteria here, constipation really, or I guess in terms of the four options, it would be option number three. And I think I just wanted to put up this question to really drive home the point that constipation is not so much just infrequent bowel movements, but all the other things, all the other symptoms that bother people the most. So that's your straining, that's your incomplete evacuation, that's your digitation. Of course, those are uncomfortable. Okay. So objectives. So I have a couple of them for you. The first one is to understand what is meant by constipation. So we already went through that. So hopefully, yeah, you're now a little bit more familiar with the Rome 4 criteria for chronic constipation. Objective two, wonder to understand why constipation is important for your practice. Three, motility and physiology of colon, just to get a basic understanding of that before we review the pathophysiology of constipation. So I guess objectives 1 through 4, I'll try to go through them relatively quickly. Mainly, this is more of a back to basics type of information before we jump into the meat and potatoes of our presentation, which will actually be 5 and 6, to understand the latest evidence for pharmacological management of constipation. So I'll be reviewing the 2023 ACG and AGA. So those are the two largest GI societies here in North America. So American College of Gastroenterology and the American Gastroenterological Association. They published a June 2023 guideline that we'll go through in detail. And how ultimately the main objective would be, how do we use all of this information that I'll present to develop a practical approach when you see a patient who's constipated in your practice? Okay. So to answer objective 2, why constipation is important in practice, first of all, it's because it's everywhere. So 8% of Canadian adults, this rises to 20% when you're 65 years old, and 30% when you're 85 years old will have constipation. So it's everywhere. And so no matter what medical subspecialty you're practicing, or even if you're doing psychiatry or family medicine or surgery, you will see people who complain of constipation. So hopefully you have some tools to manage this more than just throwing a random over-the-counter laxative at a patient. It's a little bit more common in women, actually odds ratio 1.9. So a little bit more common, or a lot more common in women, I should say. A little bit more common in non-whites than in whites with an odds ratio of 1.7. And this is US data, but it results in 2.5 yearly office visits, sorry, 2.5 million yearly office visits per year, with a $500 or $500 million spent on over-the-counter laxative products alone. So that doesn't include your more expensive prescription laxatives. Okay, so it is absolutely everywhere, which is why I thought, again, we should talk a little bit about this. So I'll jump through this slide really quickly in terms of just going through colonic motility. There's a baseline peristalsis. And so that's kind of more for physiology. There's a background non-propagated low amplitude motility. It's segmented by Haustra. This is a cross-sectional image of a wall of the colon. In the colonic wall, there are two big plexi. So there's a submucosal and then a myenteric plexus. These form the enteric nervous system. It doesn't really matter. Together, they produce a slow wave, and then they also produce a membrane oscillation potential. This is the background peristalsis. So think of this as the colon jiggling intestinal contents back and forth ever so slightly to increase absorption of mostly water and electrolytes as well. But I do want you to contrast this background low amplitude non-propagated motility with actual high amplitude propagated contractions, which actually have clinical relevance. Okay, so these, as its name suggests, high in amplitude, 75 millimeters of mercury in amplitude. They occur 6 times per day, so they're relatively rare. As you may personally experience yourselves every morning at 10 o'clock in the morning or 10:30, after your coffee or after going for a walk on a weekend, you get the urge to have a bowel movement, right? Because that's when HAPCs, or these high amplitude propagated contractions, are more active. They also occur postprandially. So sometimes, again, maybe after a big buffet dinner, you feel like you need to go to the washroom and do your number 2, right? That's because there's a very strong signal called a gastrocolic reflex, which sends signals, or essentially the stomach will tell the colon to start emptying because, hey, there's new food coming down the pipeline, right? We can take advantage of trying to induce high amplitude propagated contractions with the use of laxatives, or they could just happen spontaneously throughout the day, less so at nighttime. So to kind of give you an understanding of how, I guess, how amazing this could be, yes, Vince coffee for sure. So I think of this as being extremely fast. So this is a nuclear medicine study called whole gut transit scintigraphy. I did this quite a bit in the United States. We don't have access to it here in Canada, but that's okay. Ultimately, I'm trying to demonstrate that we are able to inject a radionucleotide called indium-111 into the cecum. And as you can see here, under the power of a HAPC, from the cecum down through the ascending colon, transverse colon into the proximal descending colon. So I like to look at my abdomen when I'm thinking about this. So the cecum is the right lower quadrant. The proximal descending colon is all the way up over here on the opposite side, left upper quadrant. And so one HAPC can push intestinal contents the length of the entire abdomen in 75 seconds. I know that doesn't really show too well, but 75 seconds, it produces really a lot of anterograde movement. When it reaches the anus, it causes it causes anal relaxation. And I guess that makes sense because you need to have decreased anal sphincter tone in order to produce a bowel movement. Okay, so these are HAPCs. They do have clinical relevance. If you have too few of them, you can get constipation, which we'll talk about specifically, a kind of constipation called slow transit. If you have too many, which is clearly not the topic of this discussion, you can get diarrhea, or if you have abdominal pain associated with diarrhea, we say that that's IBS-D if they fit certain criteria as well. Okay, so HAPC is important for constipation. In terms of pathophysiology of constipation, where did this come from? We divide most medical symptoms into primary and secondary. So for primary, there are three types. There's one called normal transit. It's associated with IBS as well. It's relatively common. About 60 to 70% of patients with constipation have this form of it. Dietary lifestyle factors are important. So those are kind of the people who don't drink enough water, they're not exercising enough, they're not getting enough dietary fiber intake in their diets, and that can lead to constipation. Investigations are normal. By the way, I would really just see if I see a constipated patient in my clinic for the first time, I would just throw off a CBC, check hemoglobin, make sure that they're not anemic. Otherwise, the investigations for normal transit are normal. Slow transit, about 5% of times people will get this. They're relatively rare. They're characterized by decreased HAPCs that we can try to diagnose based off elaborate motility studies that, again, that we'll not get to. And then pelvic floor dysfunction is a third and relatively common type of constipation that is also a little bit difficult to diagnose here, but I think it's important that all of us are aware that this can happen. So what is it? It's a discoordination between straining and relaxation of the pelvic floor muscles and anal sphincters during evacuation, right? So I just read that off. What does that actually mean? So I thought I'd show you a quick picture of an anal rectal manometry to really highlight what that means, right? So an anal rectal manometry testing is when we essentially insert a catheter that's about 10 to 15 centimeters in length into the, past the anus into the rectum. This catheter has a bunch of pressure sensors, usually 6 or 10 of them, spaced a few centimeters apart. Those pressure sensors can either detect low pressure in blue or higher pressure all the way up in red. And so at rest, you have intrinsic anal sphincter tone that's highlighted here in green. And when you're squeezing, right, so maybe I don't know, perhaps you've eaten too many tacos the night before or something, and you're running to the toilet and you're trying to make it, you're kind of clenching down there, you're recruiting your external anal sphincter striated muscles to help with squeeze, right, to prevent the stool from coming out. When you're trying to have a bowel movement, when you're evacuating, however, what you want to do is the opposite, right? So you want to generate increased pressure in the rectum proximally. At the same time, you want to decrease in anal sphincter tone. And with this positive pressure gradient, you're able to pass your stools more effectively. Pelvic floor dysfunction occurs, again, 20 to 30% of times. Patients who are constipated, they have this disease or this entity. They either, when they're going to the toilet, they're pushing, or sorry, they're trying to get rid of stool, but they're actually doing this, right? So this is not going to be helpful. You can also have decreased propulsive force, like you're just too weak up at the rectal area. Oops, sorry. Or you can have a combination of decreased propulsive force with paradoxical contraction. You can kind of see how with this pattern, stool isn't likely going to come out and people will be constipated. The best treatment for pelvic floor dysfunction is actually a type of physical therapy called biofeedback. We won't get too much into that just because, again, we don't have access to it. Secondary causes of constipation are just listed up over here. The main ones are opioids, but oftentimes they're not particularly reversible, okay? So that's kind of the background information for constipation I'd like you all to be aware of before we talk more about this, okay? So this is the AGA-ACG Clinical Practice Guidelines, again, published less than a year ago, regarding pharmacologic management of constipation. So before we get into it, they do not talk about Docosate, right? So Colace, well known in the GI community that it doesn't really do anything. I just want to present a little bit of data here. Colace was actually introduced in 1968, 15 patients, geriatric, hospitalized patients, demonstrating increase in bowel movements of treatment. But this was before 1975, where FDA actually came up with stringent criteria for NDA, new drug approvals that need to demonstrate medications actually being helpful before getting approval. Subsequent to that, there have been 6 randomized control trials comparing Docosate to a control. The control can either be placebo, in which case Docosate does the same, or in this study by McRory about 1998, when they compared Docosate to fiber actually did better. Okay, so a couple of my colleagues out in New York recently published in the Choosing Wisely, so we're all aware about that campaign. They have a segment called Things We Do for No Reason, and one of them is prescribing Docosate for constipation. In hospitalized adults, I would actually say Docosate, or I guess in all patients, it's might be something we do for no reason. They even go on to say that you should remove Docosate from your hospital formulary. Just essentially don't do it. Use something that's better that we'll talk about in the next slide. But again, don't feel too bad if you're one of the prescribers providing it, because about 15% of hospitalized patients will receive at least 1 dose of Docosate during their admission. It's very commonly used. Again, try not to use it. There are better options for your constipated patient, okay? What are those? Okay, so the guidelines, this guideline that I want to emphasize and talk about, first guideline is actually fiber use. So beside the option I've put S for suggested, R will be for recommended. Obviously, we want to follow the recommended guidelines more so than suggested. So fiber, what does the evidence show? So we do know that there are a couple of types of fiber there. If you're soluble, you have your insoluble. Psyllium fiber in particular has been demonstrated to help in 3 randomized controlled trials. This is published in the 80s and 70s, so I'm not going to show that, to increase spontaneous bowel movements, but mainly in patients who are already not consuming much fiber. So if you have your typical North American meat and potatoes type of diet, you're getting about 8 to 10 grams of fiber in your diet per day. A healthy colon needs a lot more, around 25 grams. And so psyllium fiber supplementation has been shown to be particularly effective in people who self-report, I just don't eat much vegetables, right? So thinking about that, doing a dietary history is oftentimes the first question I'll ask. And if they're not eating enough fruits and vegetables, I would say, you know what, maybe we should be increasing psyllium fiber. Other types of fibers, so inulin soluble fiber and bran insoluble fiber, you may have heard about those. Do not use, there's no evidence. So really the evidence really is for psyllium soluble fiber. That's with your psyllium husk. That's also Metamucil supplementation, trying to get them to at least 20 to 25 grams total per day. Okay, so that's a relatively easy option. The second options that we want to go through are your osmotic laxatives, okay? So we have 3 categories. One is the PEG-based one. So R recommended, this is the strongest evidence that we have. We do know that PEG 3350, it's a polymer of ethylene oxide. It creates an osmotic gradient. It draws electrolytes and therefore water into the colon, thereby leading to constipation management. There have been 3 randomized control trials. Again, these were done decades, eons ago that we're not going to get into. It does increase the number of complete spontaneous bowel movements per week, but it doesn't usually affect other symptoms like nausea or bloating if patients also have it. I do want to make a mention that I get this question, all the time. People who are constipated, they do not want to start something that has been shown to be very gentle and very effective, like PEG, because they're afraid that um, they're going to become dependent on it, right? They become addicted to it. That is entirely not true. That will never happen. You can take PEG 2, 3 times a day for 50 years. The second you stop taking it, your bowel movements will go back to how they were as if you've never taken PEG ever. So will you be constipated? Probably. That's why you took PEG in the first place, right? But will you now become someone who has colonic inertia, who will never poo ever again? I don't think so. There's no evidence to suggest it, right? I think PEG also demonstrates strongest evidence because we have studies going up to 6 months showing that it's effective. Again, it's probably effective indefinitely. It's also very titratable, right? So you can use one capful, which is 17 grams once a day. You can use one capful every other day. You can use, I don't know, 38% of a capful every 14 and a half hours. It doesn't matter. Whatever you pick, it's entirely titratable in that way. So it's very easy to administer. The second type of osmotic laxative is your magnesium-based one. So that's your milk of magnesia or magnesium hydroxide, anywhere from 400 to 1,500 milligrams per day. Unfortunately, especially if patients have creatinine clearance of less than 20 to 30, we want to avoid potentially causing hypermagnesemia. So it's something to watch out for. It also receives a suggested guideline only because studies have only demonstrated it to be effective for 4 weeks instead of 6 months. Again, it probably is okay using it indefinitely if they don't have renal dysfunction. And the last one would be, or last category of osmotic laxatives would be your non-absorbable carbohydrates. So that's your lactulose. I would personally recommend not using lactulose. The only time I use it is in a setting for prophylaxis and treatment of hepatic encephalopathy in decompensated cirrhotics. It does give patients a lot of symptoms, but sometimes if patients have been on lactulose forever and they like it, then sure, we could continue that. I like to think of osmotic laxatives as maintenance therapy, right? So we want to be giving constipated patients osmotic laxatives once a day or once every 2 days or a couple of times a week as maintenance therapy. If that doesn't work, the recommendation is actually to move on to stimulant laxatives. So you have your diphenylmethane derivatives, so those include your bisacodyl or your sodium picosalax, right? So we know that from bowel prep. Bisacodyl and sodium picosalax eventually both get converted to the exact same product inside your gut. It's a derivative called BHPM. It directly stimulates colonocytes to do and generate HAPCs that we talked about. You can use PO or PR depending on how a patient wants to take it. If you're thinking about using a suppository, Dopalax suppository would be my go-to. You may have also heard of Senna or your anthraquinone derivatives. These are also stimulant laxatives. They work a little bit differently. They actually work by causing direct colonic injury. And as a result of that microcolitis, you're actually leading to epithelial damage, increased water secretion, increased electrolyte secretion, constipation management. I usually only use Senna or these anthraquinone derivatives. So that could be other things like cascara, aloe, rhubarb, for instance. If I have a patient who really just wants, like they want to go with a natural approach and they're really afraid of medications, for instance. But use something that's probably a little bit more effective. So that's your bisacodyl stimulant laxative as rescue therapy if your osmotic laxatives do not help. All right. Next, we'll move on to your secretagogues. So secretagogues, these are the newer prescription-based medications that have come out into the market 10, 15 years ago. The first one that we have, it's the only one in class of the type 2 chloride activator. That's your lubiprostone or Amitiza. I don't even think it's available here in Canada, so we won't talk too much about it. You can use it. Unfortunately, a lot of people, if you do see people on it or you have heard of patients taking it, people tend to stop. 35% of patients do develop nausea that requires discontinuation. However, lubiprostone is approved specifically for treatment of opioid-induced constipation. Again, that's a very rare subset of patients. let's talk more about the GCC agonists. Okay, so these are a very powerful group of medications that I use personally quite a bit. How this works is that this patient eats it, it goes into their gut epithelium, so both the small bowel and the large bowel. What it does is that once it goes into the receptor, it converts intracellular guanosine triphosphate into large amounts of cyclic guanosine monophosphate, which have two roles. The first, on the apical surface, it opens a CFTR channel. Chloride is secreted into the lumen. Sodium is secreted into the lumen to maintain electrical neutrality. Then water, of course, follows sodium. At the basolateral surface, however, cyclic GMP also leads to nociception. So in an unknown extracellular target, we think of it as reducing afferent communication and pain relief. And I guess that's what the schematic is trying to show with decreased amount of waves here. Okay, so GCC agonists help with both constipation and pain, which could be very effectively used. What's the evidence? So linaclotide, the first-in-class GCC agonist. This is a paper published about 10 years ago. There are 3 randomized control trials. This is the biggest one, 800 patients comparing linaclotide at 290 micrograms to placebo. You can see that within 1 week of use, people who were randomized to linaclotide had a significantly increased amount of change in CSBM, so that's complete spontaneous bowel movements, compared to the people who were randomized to placebo. The duration can last 3 months, so 12 weeks here. At the end of the treatment period, the patients who initially received placebo were then given linaclotide, and you can kind of see afterwards for a subsequent 4 weeks, their bowel movements improved. The patients who were initially given linaclotide were re-randomized to either continuing to receive linaclotide, so that's over here, or to get randomized to placebo, in which case their constipation management kind of goes back to where the placebo is, right? So for 4 months, linaclotide can maintain a improvement in constipation. In terms of abdominal pain, how does that work? So first of all, again, they're comparing in a treatment group, linaclotide 290 micrograms to placebo. You can see that by week 6 to week 7, there's a large difference in change in worst abdominal pain. So this is a numerical rating. They use an 11-point numerical rating scale. Patients taking linaclotide at 290 microgram dose had a decrease in overall pain. Same thing at the end of the 12-week treatment or initial treatment period. The patients who are randomized to receive placebo, who didn't get linaclotide, they get better. The patients who got linaclotide first, who were then re-randomized to placebo, got worse. But if you were given linaclotide first and then re-randomized to receive more linaclotide, you continue to do well up to 16 weeks. Okay. The problem with linaclotide is that a lot of patients will complain, and this is not usually a big complaint for the most part on their end, is diarrhea, actually. So around 10 to 15% will actually have to discontinue the medication because of diarrhea. We tend to think of linaclotide as working in a pH independent manner. So it affects both the small bowel and colon GCC agonists. There's another company, they recently came up with plecanatide, that's your Trulance. It's a pH independent GCC agonist. What it does is it only binds to the duodenal GCC agonist, and I think what they market it as could potentially causing less constipation, sorry, less diarrhea, although the evidence doesn't really show that too well. They both cause diarrhea to the same discontinuation rate. In terms of the evidence, very similar, a 12-week period involving this study, 400 patients in each group. Placebo compared to plecanatide at both the 3 and the 6 milligram dosing do not do as well as placebo in a statistically significant manner very quickly after starting. At week 1, you can already see the difference. By week 12, the difference is maintained. The treatment is still working, but there's a follow-up period afterwards for 2 weeks where the patients who are given The real drug, the plicanatide, again at 3 and 6 milligrams, were then given nothing. Their symptoms also got worse. Okay, so their weekly spontaneous bowel movements went back to where placebo was, which is, we think of it obviously not being particularly effective. Okay, so both linaclotide and plicanatide, they're given recommendations based off improvement in bowel movement frequency for at least 16 weeks, so 12 to 16 weeks, but also decreased nociception. I do want to mention there's a new kid on the block here. The drug companies kind of bother us quite a bit to try to prescribe more of this medication called tenapanor. It was not reviewed by this guideline. It is a new in-class sodium hydrogen exchange 3 inhibitor. What does that mean? So it's essentially a secretagogue. It just does the opposite as the GCC agonists. What it does is that it's going to stop the it's going to stop the intra I guess colonocyte or enterocyte absorption of sodium because it inhibits this channel. As a result, sodium stays in the lumen and obviously water falls sodium. The interesting thing about this medication is that it also has at the basolateral surface decreased nociception. So again, the waves frequency goes down over here. I guess that's what they're trying to illustrate. But it has also been used as a treatment for chronic kidney disease-induced hyperphosphatemia. So I'm not sure whether my nephrology colleagues are using it. Here in Canada, there's a medication called Xphozah or tenapanor, 30 milligrams twice daily. What this does is when there's too much sodium in an intestinal lumen, phosphate gets stuck there. As a result, we actually get decreased paracellular flux of phosphate into the bloodstream. Anyway, I just thought that was interesting. But is there a role for tenapanor in our market? I'm not exactly sure. I haven't really used it too much myself. Okay, so hang on, there's just a couple more minutes here. So last category of drugs I want to talk about are your prokinetics. So these are your 5-HT4 agonists. So you have prucalopride and tegaserod. We'll talk more about prucalopride because it does receive a recommendation guideline. The evidence from this is 2008 now, so published by my personal mentor, Michael Camilleri, in the New England Journal of Medicine about 15 years ago, comparing prucalopride at the doses of 2 and 4 milligrams, so pretty large study, 200 participants in each arm, to placebo. You can see that within in all weeks 1 through 12, prucalopride at the 2 and 4 milligrams significantly increased the number of patients or the percent of patients with 3 or more spontaneous complete bowel movement. So this is a relatively old study, but it works very well. I find it to be particularly effective in your patients who have chronic constipation, but also gastroparesis, as it can also accelerate gastric emptying. In fact, we call it pan-GI prokinetic. It works on every single cell within a GI system. They're actually studying prucalopride for the use of esophageal dysmotility. So sometimes the esophagus is not squeezing too well. Can prucalopride help accelerate transit as well? So anyway, just a little bit, just a tidbit there. Tegaserod, it's also a selective 5-HT4 agonist. It also increases HAPCs. It also helps with small bowel and gastric motility in addition to colonic motility. The problem is no one prescribes it, and so they actually removed it from the market, not because of side effects or anything, or not because it doesn't work, just it's not selling well. So how do you put all this information together? In patients with CIC, so that's your constipation, IBS-C, so that's a constipation with pain, and in OIC, opioid-induced constipation, the guidelines do provide this chart that I kind of just made up here in terms of your dosing and which ones you would pick to help see and treat your patient. Okay. Just to kind of really hammer home the fact that constipation is really it is not just a symptom. This is the workup that we used to go through. Again, I don't want you to remember any of this. This is more for maybe for academic and interest sake. I'll give you a more practical approach in the next slide. But when we see a constipated patient in a clinic, of course, you want to do a history and physical examination. You want to do some basic testing, main one being rural anemia. If the patient does not have or sorry, if they're not up to date for colon cancer screening, you want to do a colonoscopy. But besides that, I would say, try your lax, try your fiber. If a patient is kind of one of those meat and potatoes type of diet consumers, your osmotic laxatives and stimulant laxatives, if that doesn't help, they actually recommend that we do pelvic floor testing relatively early, right? So that's what for anal rectal manometry, balloon expulsion test. If you have an inconclusive result, you can actually do some type of radiographic defecography. Again, not really relevant here. If there's no pelvic floor dysfunction, you can either do transit studies with X-ray SITS marker studies or wireless motility capsule studies. And depending on what this shows, so this will give you your diagnosis of the type of primary constipation, right? So that's your pelvic floor dysfunction, normal transit, or slow transit that we talked about. You would then manage patients in different ways. I would actually say it doesn't really matter too much what type of constipation they have, because here we give them laxatives anyway. So by the way, patients with pelvic floor dysfunction, the best treatment is biofeedback physical therapy, but a dysfunctional pelvic floor is still able to handle liquid stools better than hard stools. So we would still recommend laxatives as a first-line treatment. So that's kind of what this box is saying. If they improve, great. If they don't improve, you can consider one of the newer pharmacological agents. We don't really have to repeat colon transit testing. I don't think anyone ever does that. But if they're still not improving with all those new drugs that we talked about, we would actually test to see what your stomach is doing. Because if your stomach is slow, then you have pan-GI dysmotility. You are a much harder phenotype to treat. And so a lot of it is just trial and error with all of you throw the kitchen sink at them and hope for the best. But if they don't have gastric emptying delays and they have isolated colonic dysmotility, we can even consider, depending on what a very fancy test called colonic manometry can tell us, actually sending for surgery, right? So if your colon is completely broken, based off of this study, you would actually say, you know what, we can actually just take out the colon entirely and do an ileorectal anastomosis. Sometimes you can also do temporary loop ileostomy. Of course, this is very, very advanced treatments for constipation. Again, personally, I've seen about 1,000 or probably even more constipated patients who've gone down this algorithm so many times. I've only had one person who went down this route. They've got a colectomy. They had an ostomy. It was the best thing that they've ever done, just because it got rid of such a significant symptom of theirs, which, of course, for them is not just constipation, right? Okay, so what does all this mean for your practice? Okay, so a practical approach to constipation would be remembering what constipation actually means in the first place, right? That's not just infrequent bowel movements, but that's oftentimes all the other symptoms that come with it. Rule out secondary causes, biggest ones, opioids. If easier said than done. Next, assess soluble fiber intake, do a dietary history, jack up the fiber if they need to. For routine use, I recommend PEG 3350 for all patients. If that's not helping, I recommend PO or PR bisacodyl Q 2 to 3 days if the above is not working. If that also doesn't work, go to your GCC agonist, pick one, just stick with linaclotide, 145 micrograms daily. By that time, if they're still not getting better or they get a lot of diarrhea, refer to GI. Myself, or I'm sure a lot of my other colleagues will be happy to see and help this patient with constipation. Okay, so this is kind of a practical approach, but hopefully you can appreciate that constipation is not just a symptom. It can be very, very refractory to treatment. There are a lot of new agents out available in the marketplace that we can use to treat more severe constipation. And as you can see from my previous slide, the diagnostic workup of constipation can be extremely detailed as well. Okay, so with that, I end my presentation. Obviously, I'm happy. We didn't get timed out by Zoom, which is nice, yet anyway. So I'm happy to entertain some questions either right now, or you can always send myself an email, aliu1@shn.ca. I'm usually pretty good on email. So I look forward to chatting with you soon.
Brian, and have you had any experience with the colon vibrating capsules?
So I have not. It was recently introduced, I think, just within the past year. I'm not sure whether we can get that here in Canada. When I was just leaving New York last year, the drug reps did come and find me. We talked a little bit about that, but even at that point, even the US insurance companies were not covering it. So I have zero experience using it. I think there potentially is a role for the vibrating capsule if we use one of those secretagogues that we talk about, and everyone gets, or sorry, yeah, a patient gets diarrhea with all of those, right? And I think there might be a role for the vibrating capsule, but no, I've never used it before.
When I was a kid, we used to buy Mexican jumping beans at the CNE. Maybe a
Did it
cheaper
work?
alternative.
Yeah, it's interesting. So for those of you who have not heard about this, there's a company, I think it's called Vibrant. They sell these capsules. Each capsule itself can wirelessly communicate with like your smartphone app, and patients can look at their phone and see how far along the GI tract it's going. It vibrates at a certain frequency, and you actually eat it about 2 to 3 times per day. And what it's supposed to do is stimulate some type of colonic motility. I don't think anyone really knows how it works. It is not FDA approved, but it's one of the earlier stages of FDA approval. They call it like FDA. It's being analyzed by the FDA or something, but it's not a drug. It's a device. So I guess they have different pathways for approval. But yeah, it will be interesting to see. Maybe it'll come to Canada.
Thanks, Andy.
Yes, of course.
Great talk, Andy. Eric, you stole my thunder. I was going to ask the same question. It says here it's FDA cleared, whatever that.
Yes, that's the term. Yeah, FDA cleared, not FDA approved, but again, devices have different pathways.
Gord, I think you should start a study on that one.
Help me in.
Andy, thanks for the talk. That was really well done. Thanks a lot.
You're very welcome. Again, email me if you have any other questions. Okay.
Andy,
Hello.
Grant here. Great talk. I got a few comments and a couple of questions for you since I have you on the line here. So great talk. As you know, the issues around treatment and or investigation, more on the advanced end, are limited by accessibility and costs, right? Like, all of the ones you talked about beyond even PEG, which, is standard. Patients don't want to, it's over the counter, it's not covered. And they'd rather grab the lactulose because they can get a prescription for it, even though we clearly know that PEG is better than lactulose.
Yeah.
So that is, and then the pelvic floor stuff is always very challenging. Yep. I have several patients who, you can even tell based on a rectal exam that they probably have pelvic floor dysfunction. But again, biofeedback is challenging to get. Pelvic physio, unless you have extended health benefits.
Right.
I try to access free biofeedback, but I don't think it's that great. And of course, the patients need help. They need guidance that way.
Right.
So, it's frustrating, to be able to know that there are things out there that can help them, but it's very difficult to access, both pharmacologically and, physiologically.
Yeah, and to your point about the pelvic floor issue, even if we can get rectal manometries and we can get pelvic floor testing, or pelvic floor dysfunction treatment, a lot of it also depends on patient engagement too. Like if they're not going to try and they don't believe in it, then it's not going to work. But it also depends on the physical therapist's engagement. And of course, my experiences were if you go into PT school, you're probably wanting to see like sports injury or neurological injury, and maybe the PTs who end up doing pelvic floor. I'm not sure whether this is really they want to do. Good for them if they do, but if they're not engaged, then of course the patients aren't going to benefit either.
So 2 questions for you. One, abdominal massage for constipation.
Oh, okay.
Can you comment on that? Because I have a few patients who swear by it.
Okay.
2, probiotics. The role of probiotics, if any, for IBS-C, and or just constipation in general. Because as you know, I believe Activia yogurt, for example, advertises bowel regularity as one of their products. And 3, SIBO subtype with methogenic bacteria causing constipation. And have you ever treated that or tested for that?
Yeah, so the first question, abdominal massage, I can't explain why. I do not believe there's any evidence to show that this works. I don't even know what protocol you would use. I have some patients who swear by it too. I feel like just because constipation is also a functional disorder, for the most part, if there are no secondary causes, I feel like that might just be like they feel like they're engaged, they feel empowered, they're doing something, and things just work. So I have a couple of patients, they swear by it. I usually say, you know what? Cool, please continue doing it. If it's working, it's working. But certainly no evidence that I'm aware of that demonstrates that we should be doing this like first line or we should even be trying this for all patients. Regarding your question about the methogenic, so I guess that's an archaea. It's similar to bacteria, but a little bit different, I guess. I think there is some evidence demonstrating that that type of small intestinal bacterial overgrowth, which is mostly known to cause diarrhea and cramping, can actually lead to constipation. I have tested for it a couple of times in the States. I'm not sure whether we're able to get type of breath test here. The last time I checked when it came was no. The treatments for, so if I do think that they have potentially risk factors for, so if a patient has constipation and they have risk factors based off of history for developing SIBO, so those are people with chronic opioid use, right? Those are people with a RULM, right? So if they've had previous Roux-en-Y gastric bypass or a Bill Roth 2, there's like, we think there's stagnation of low colonic motility and the bacteria are just hanging out in a small bowel, right? We think that there's that risk factor. If they have scleroderma, the colon is doing nothing, the small bowel is doing nothing, you can almost assume they have SIBO. Without testing, you can try giving the rifaximin and neomycin, right? I think that's a combination that we can try. I haven't tried it here because I can't even get rifaximin by itself. And so sometimes you can try to just use the neomycin if they have risk factors based off of a history. So I think here with more limited resources, I would just say, you have constipation. If it's new-ish after a clear insult, like a bypass surgery, I might think about that and we can try empiric neomycin, maybe try to get some rifaximin, but I'm not aware of any testing here that's available, unfortunately. And sorry, what's your second question? I'm drawing a blank on that.
The probiotic question.
Oh, yes. Okay. So yeah, so my thoughts on probiotics are there's no evidence that show that it's helpful for IBS-C. I think it does carry in one of the other guidelines, it does carry you can try it. There's like just a expert opinion saying you can try it. You can try for 1 month. If it helps, great. If it doesn't help, then okay, well, stop wasting your money. I think really the evidence for the probiotics does come from prevention of C. difficile, recurrent C. difficile infections, and that's the only time I would actually really use it. For most part, Align and VSL number 3 and Activia and VisBiome, I don't use it much in my practice.
Thanks.
Thank you. Okay, so I think that's it. I'm glad we didn't get cut off again. Send me an email if you have questions. I'm happy to entertain them. And thanks for listening, everyone. Please have a great day.